Thank you very much, Mr. Chair. Distinguished guests, welcome. My presentation is not too long because there isn't a lot of safety issues. This was already pointed out by the previous speaker, but I will just try to give you some hints and some advice about its clinical use. These are the general subjects I will address in my presentation. First of all, I will talk about the safety concerns, such as heating up, magnetism, voltages, or if the patient has an implant or a stimulator in his brain, what will happen if you use TMS. And secondly, I will discuss the adverse effects, such as seizures, syncopes, cognitive changes, acute psychiatric changes, as well as other biological effects. This is an outline of my presentation. I only want to show you one single technical slide because this is everyone who is using TMS will have a clear idea about its mode of action, but for the non-users, this will provide an insight about the mechanism of action of this. So there's only a clicking sound that comes from the machine, and they talk about certain protocols. What are these protocols? What is 5 Hertz? What is 20 or 25 Hertz? This slide addresses this question, and Dr. Honor already discussed this issue. High frequency is considered anything about 15 Hertz, and low frequency is 1 Hertz. This 1 Hertz means the number of pulses per second. So this one gives 10 pulses in 1 second, which means it's 10 Hertz. These are conventional treatments, so they have a certain rhythm, they have a certain fixed interval where the pulses are delivered. For example, if 5 pulses are administered in 1 second, it has a frequency of 5 Hertz. This is a current induction. What do we mean by pulse? Or it could be 10 pulses per second, which corresponds to 10 Hertz. What we apply in the clinic, of course, are not those conventional treatments. Now, when you talk about a pulse, we refer to individual pulses. Our treatments have a specific shape. So you don't have a specific setting for the different psychiatric conditions on the device itself, so you have to adjust the settings yourself. So in 2 seconds, 40 pulses, which corresponds to 20 Hertz. This is how we just set it. We most of the time use 20 Hertz, sometimes we use 10 Hertz, and then we have to, you can adjust the interval between the deliveries of the pulses. And here is an example of 28 seconds, and this is again followed by a second set of pulses. Then we then determine the number of total pulses, like it could be 1,000, and the machine will continue until 1,000 pulses are delivered. Then for a specific treatment, we set the device 20 Hertz, 20 seconds intervals with a total pulse count of 1,000 pulses. And the patients will discuss it in front of the door. One says, it took me only 10 minutes. The other one says, my treatment took 45 minutes. One patient is treatment with 1 Hertz, and the other patient is treated with 20 Hertz. This creates a difference, of course. Although we don't publish it ourselves, but we hear it from the literature, there's something that's called continuous theta burst stimulation or intermittent theta burst stimulation. This is where the frequency is very high, like 50 Hertz. However, in 1 second, not 50 Hertz are delivered in row, so only 3 pulses are delivered, but at a frequency of 50 Hertz, or there's something we call quadripulse. So only 4 pulses are delivered, and there is a break, there is a waiting time until the next pulse. So these are just details, and they concern safety. And most of the safety concerns are related with the technical settings of the device. They have been defined in the guidelines. So the guidelines tell you what Hertz is safe, or how long the time between the 2 pulse sets have to be for the delivery to be safe. So you have to follow the recommendations and the guidelines. Okay, I will just go quickly. We have already discussed the different types of coils. The basic point is we can reach a depth of 1.5 to 3 centimeters in the cortex with normal coil. And there's this figure 8 coil, or the butterfly coil, provide a more superficial stimulation, and if it's a bit curved, the pulses are transmitted a bit deeper. So in terms of safety, as much as frequency settings, the shape of the coil also plays an important role. Another important issue here is this, what was described by Dr. Onur, is the motor threshold. This is about what kind of stimulus you need in order to observe a movement in your finger. You look at the strength, and then you provide a shock at a certain percentage. So if you deliver a shock that is 300%, and then independent from the frequency, the procedure becomes unsafe. So these are the parameters that have an impact on the safety of the procedure. Now let's discuss the safety issues. One of them is heating up. So you just give an electrical shock to the brain. Does the brain heat up, and does it lead to tissue damage? According to the studies, the heating up of the tissue is less than 1 degree Celsius. However, if the area of application has also a cyst where there is a low perfusion or there is atrophy in the same region, then the temperature elevation is even less. This is not an invasive procedure. You create a magnetic field, so there is not a visible object that penetrates the brain. Instead, in case of the deep brain stimulation, it's the same. There's only a temperature rise of 0.8 degrees Celsius around the electrode, and thus plastic electrodes with a low conductivity are used. If the temperature in the brain increases up to 43 degrees, then it may cause, in this case, it may cause damage. Otherwise, it may be neglected. If there's an aneurysm clip, or if there's an electrode in the same region, of course, the temperature elevation around that object will be higher. Now, currently, we have all the clips and electrodes available in the market are safe. However, if something new comes up, a new clip is introduced, then we have to revisit the safety concerns of the TMS procedure, and we have to check whether there is a temperature elevation associated with the use of this specific clip. And second issue could be magnetism. At the end of the day, the magnetic field is induced, and metals are sensitive. Some metals are sensitive to magnetisms, and they can be dislocated. If the patient's, there's a metal object in the patient's brain which is magnetic, it may be moved. So there is a similar risk to the MRI scans. For titanium, there is no risk, and most of those objects, those implants, are made of titanium. Steel could be risky. However, if you look at clips made of steels, they only move by 0.303 millimeters. And the reason is that impulses only reach a certain depth, and which is really bad for the efficacy of the procedure, because our stimulation doesn't reach deeper surfaces. Cochlear implants could be more dangerous because they are more superficial. They can be translocated, dislocated, and secondly, they may malfunction. Similar to MRI, metal objects have to be removed before you start the procedure. Now, this is about the dislocation of the cochlear implants, and second, it has to do with electromagnetic induction. So if you have an electrical device, you create a current, although this device is switched off, or you may just interfere with the function of the device. Here you see a cochlear implant. This is the only absolute contraindication for TMS, because it just breaks down if you use TMS with a cochlear implant. You know, there is a transmitter, there's a processor, and in the inner side you have the cord, and the electrode goes down into the cochlea. So when you just deliver a stimulus, the risk of dislocation is very low, but it may interfere with the functions of the device, because it's a complex electrical device at the end of the day. And secondly, our first speaker, Dr. Murat, talked about the brain stimulation and vagal nerve stimulation. So what should we do in this case? And before TMS, many other interventions may be done on the patient. Here the issue is not the electrode itself, because there is only a slight degree of dislocation. What really is a concern for us is the location of the pulse generator. If the pulse generator is close to this area, of course it will interfere with its function, but most of the time the generators are located in the chest. A certain distance is considered to be safe. If you get closer, if you don't get closer than that, there's no safety concerns, and cardiac pacemakers are considered to be safe too. In terms of cardiac pacemakers, or of course if you just put the coil close to the cardiac pacemaker, it's of course not safe, and you can't be sure what the technician is doing, whether he's moving the coil close to the cardiac pacemakers. You can just put up a life jacket on the patient, which will just create a safe distance for the cardiac pacemaker. Exposure to magnetic field, this is something that is really a concern for the patients. What will happen to if it's used on pregnant women? The magnetic field that is created by the TMS is not a medical risk. What really is a question, if you use it successively, it could be a risk for the technician, because they are exposed to this magnetic field much more than the patients. So if you perform a TMS session, the magnetic field exposure is 1% of the legal limit. However, the technician may have performed 10 such procedures in a day. It's a low risk, but we really don't know what will happen after a month or 3 months or a year when this procedure is continuously performed. We don't, unfortunately, have any safety data on this use, on the chronic use. Now let me discuss the adverse effects, which are hearing, seizure, syncope, and cognitive effects too. I have this chart. So what we are really concerned about is seizure induction. What's the real risk here? So far, 1.4% has been reported, and in the normal population, it's 1%. Patients on antidepressant, the risk is higher than 1.4%. There is a risk of seizures. This is the most severe side effects, and secondly, the development of acute hypomania, and finally, there may be transient hearing changes. There are not much reports about it, and it's easy to take precautions against them. About hearing, why does it interfere with the hearing of the patient? Because normally, the sound that is created is around 110 decibels. Of course, newer devices create less sound. However, this may go up to 140 decibels over the time with some wear. The machine may become more noisy, and therefore we give an earplug to the patients. This is a sufficient precautions. In some of the rare cases, there may be a transient elevation in the hearing threshold. Just keep in mind that when you go to a disco with a warning about hearing, with an effect on the hearing function, there's 120 decibels, and a jet engine creates almost 150 decibels. If there is pre-existing hearing impairment, first of all, you should do a hearing test in order to protect yourself from the legal perspective too, and then you should document the results of the hearing test. If there's an existing hearing impairment induced by high volumes, in this case you have to explain to the patient. You may use some plugs that are just placed inside the ear, or you may use earplugs which are placed on the outside of the ear. But so far we have never experienced an issue about hearing in children. The problem is that there are no studies on hearing, and they have more sensitive ears too. The most serious side effect are seizures. This is something we are afraid of. This has to do with the hypersynchronous activity of neuron groups in the gray matter. This is due to the imbalance of the excitatory and inhibitory synaptic activity. 17 cases have been reported in 2014, and one of them from our own clinic. I will just give you a brief summary of those cases. Even in case of a seizure, there's nothing unexpected that happens. In one case, they couldn't be sure. It's just started 6 hours after the seizure, and therefore it's considered to be a pseudo-seizures. And the EEG came out normal too. In one tinnitus patient, a convulsive syncope. In one MS patient, because there's also already a pathology in the brain, there is a high risk involved. There's a seizure induced by a single pulse, but this patient had already MS lesions in the brain, and the patient was olanzapine, which means that the risk was increased already. In one patient, there was a history of epilepsy in the family, and the patient was on lithium and chlorpromazine, and there was another seizure. Another patient was using a proconvulsant agent, fluoxetine. Apart in all the other patients, there is an application that is beyond the safe range, and there was a sleep deprivation in another patient, and therefore, so we assess those risks in our patients. Say the patient has a seizure, we really don't have to start an anti-epileptic of this patient. The patient does not continue as an epileptic patient, only we have to discontinue this treatment. So if you just remove the triggering treatment, there are no other seizures. So this is a frequent question asked by the patients. So about TMS, you tell the patients it may induce epileptic seizures, and it's also used in resistant epilepsy. Dr. Honor already mentioned that the low frequency, low pulse treatments inhibits a specific area, and thus it may be used for the treatment of convulsions. So what's the issue with us? This may be an epileptic patient with a depression, which requires a high-frequency treatment, but the patient has epilepsy. Instead of giving high frequency from the left, we may administer low frequency from the right side. You will achieve a similar effect. This is one way to get around it. And on the other side, in 152 patients, once weekly TMS was given and there were no seizures. And the rate of seizures in epilepsy patients after TMS is only 1.4%. Of course, we have to assess the history of seizures, medications, and other comorbidities that may have an impact on the cortical excitability. And it may be high risk for patients if you use 20 to 25 Hertz in 110, 10 to 130%. What we most frequently observe in terms of scary side effects is syncope. It's like the normal syncope. Patients are really very anxious because it's like sitting in the dentist chair. Vocalization, automatism, incontinence, sometimes there may be hallucinations, the patient may fall and injure himself. I've seen this in 3 or 4 patients. One of them just improved very rapidly. Sometimes it's really hard to make the distinction between seizures and syncopes. In syncope, the patient's consciousness returns in a matter of seconds. First of all, they describe there's a narrowing of the visual field. Well, typically, they would tell you that they have to sit down or they will pass out, and even sometimes, even before you switch on the device, this is what the patients tell us, because they are really very anxious. There may be a loss of the peripheral pulses, bradycardia, GI symptoms, nausea, dizziness, and paleness are characteristic for syncopes. So it's really not hard to tell just by looking at the patient between syncope and seizures. Local headache is very subjective depending on the pain and threshold. The type of coil and the stimulation parameters may be important in terms of factors. To be frank, it's not a serious pain, but it's a subjective symptoms that is described by the patient. It's reported in 28% of the patients included in the studies. However, if sham is used, again, there is 16% headaches. And dropout because of the pain is seen in less than 2% of the patients. I haven't seen a lot of patients who have discontinued the treatment without headache. So if there is no reduction in the pain, if you just administer lidocaine cream, why do the patients experience headache? There may be trigeminal stimulation, there may be a muscle contraction induced by TMS, there may be postural problems, or because of cerebellar excitement, there may be a pain in the neck, and there may be nausea. This pain disappears when you remove the coil. However, if the headache is persisting, this will be reported by the patient. Mild analgesics will be helpful. As far as I know, there are no patients where a migraine headache was triggered by the TMS. This type of headache usually occurs in the first days of the TMS. And if the patient really complains about these pains, what you need to do is to reduce the frequency. Cognitive changes like a feeling of fatigue, inability to focus, and memory problems have been reported, but they are very rare. In 39 studies with more than 1,200 cases, and 12 studies, a cognitive improvement has been reported. In 3 studies, at least one test was impaired, other tests were normal. Acute psychiatric changes include, similar to other antidepressant treatments, the patient may switch to a manic state, and so far 13 cases have been reported out of 53 studies. We have reported 4 cases from our own clinic, but there's always this risk, when you see the patient is with a depression, then you ask yourself the question whether it's unipolar or it's bipolar, and we will see the patient in a manic state later on. The risk has been reported as 0.84% with TMS, but with the sham it's only 0.73%. I only have a couple of slides left. At the same time, apart from TMS patients, bipolar patients who are on mood stabilizers, there is a natural switch to the manic state in 2.3 to 3.45% of the patients. We should be aware of this risk, but we don't need to be concerned about it. Apart from those, sleep deprivation, suicidal ideation, anxiety, agitation, and psychotic symptoms have been reported, but they may be part of the natural course of the disease, and they are not higher as it is observed with medications. Psychotic symptoms or suicidal ideation has not been reported with healthy individuals, but such symptoms disappear when you stop the treatment. Other biological effects are not important, so I will just skip over them. We don't see anything from outside, but we have to visit the question of histotoxicity. In a post-mortem study, no structural changes have been observed, and in the imaging studies, no structural changes have been observed. In one patient in stereo-temporal cortex, bilateral gray matter changes have been observed, but in a couple of days they disappeared. There are certain effects on the immune system which are really hard to interpret, because there's lateralization involved. When you stimulate the left hemisphere, the circulating lymphocytes count increases, and the opposite is true from the opposite side of stimulation. It's just a piece of information for those who want to carry out research on this issue. Autonomous functions. It's safer compared to medications, especially compared to serotonergic drugs. The vasomotor reactivity will be reduced, and therefore patients have to be careful with acute stroke patients. This is my email address. You may always send me your questions via email. Thank you very much.